Now we are going to start with the last entity, that is the plasma cell neoplasm. So this is what the classification looked like in the 4th edition of WHO. So they were having non-IgM MGUS was there as the precursor lesion. Plasma cell myeloma was there, and this is same as in the 4th edition. In the new edition, this is also same. Plasmacytoma again is also same as it was there in the 5th, as it is there in the 4th edition. So in the 5th edition, it is the same. Monoclonal immunoglobulin deposition disease, again it is same over here as well. And plasma cell neoplasm with associated paraneoplastic syndrome, everything is same, just that this is now a recognized entity. It is no more provisional, and a new thing that has been added is ASOP. Okay. Apart from this, a lot of changes is there in the monoclonal gammopathy of undetermined significance. On the precursor lesions, there are a lot of changes. Okay. So let us see what are the changes now in the latest 5th edition. In the latest 5th edition, if you look at the plasma cell neoplasms and other disease with paraproteins, so monoclonal gammopathies has been introduced as an umbrella term. It is a new term, and they have introduced certain new entities. So what are these new entities? If you see, first of all, this monoclonal gammopathy wasn't there before. It is now being introduced. Okay. Now, if you see, previously in the plasma cell neoplasm, only non-IgM MGUS was there, and IgM MGUS was outside the umbrella of plasma cell neoplasm. It was under a B cell neoplasm. Now, both the monoclonal gammopathy, whether IgM or non-IgM, they are included under the same new heading of monoclonal gammopathy. Now, very importantly, 2 new entities have been introduced in this edition. Cold agglutinin disease is officially a monoclonal gammopathy. Okay, and monoclonal gammopathy of renal significance, it is a new entity that has been introduced in the 5th edition of the WHO. It was not there in the 4th edition. Okay, so a new umbrella term has been introduced, that is the monoclonal gammopathies. It includes 2 new entities, that is the CAD and the MGRS. Non-IgM MGUS is similar in the previous as it was there in the previous edition, and IgM MGUS just from outside it has been brought inside. So a new umbrella term has been introduced, monoclonal gammopathy. Okay. Disease with monoclonal immunoglobulin deposition, same as in the previous edition, just that the primary amyloidosis is now termed immunoglobulin related AL amyloidosis, and light chain heavy chain deposition disease is called as monoclonal immunoglobulin deposition disease. Okay. Heavy chain disease, a very important upgrade. It was previously outside the umbrella. It was outside the umbrella of plasma cell neoplasm. Now it is included under the umbrella of plasma cell neoplasms. Okay. So this is a very big chain that has been introduced. So everything is same. Mu, gamma, alpha, heavy chain disease is same. Now plasma cell neoplasm, if you see, everything is same over here. Whatever was there in the 4th edition, everything is there, just like certain new paraneoplastic syndromes. Like Temple syndrome, if you see, it was a provisional entity, now it is a 100% recognized entity. And ASOP syndrome has also been introduced in this particular heading. So if you can appreciate over here, these are the major changes there in the plasma cell neoplasm in the 5th edition of the WHO Hemat as compared to the 4th edition. Myself, Dr. Jibran Ahmed presents to you Simply Pathology, and today we are back with a very important lecture. Today we are going to read about the WHO 5th edition based lymphoid B cell and plasma cell update. So in the previous update of hematology, we have already covered in details about all the updates with regard to myeloid proliferation, and in today's lecture we are going to see the lymphoid update, especially the B cell lymphoid neoplasm update and the plasma cell update. So let us begin today's topic of discussion without wasting any more time. So let us see some of the major changes that are there in this particular section. So in the 5th edition, so remember this HIM 5 means WHO 5th edition. Okay. So the provisional entities, okay, they were not created in the latest edition of the WHO, as these by definition they lack sufficient evidence. So in the 4th edition, you must be seeing many provisional entities, but provisional entities, they were not created in WHO Hematology 5th edition. Now, since diagnostic resources are not universally available, so they had essential and desirable diagnostic criteria for each entity was defined. So why it was done so? Because, for example, whatever facilities are present in the first world countries like America, UK, Europe, okay, they are not available in third world countries. Okay, So that is why to make diagnosis possible and easy, they are having essential diagnostic features which is going to facilitate overall diagnosis at all places. And they have certain desirable diagnostic features which are going to further refine the diagnostic criteria. So let us see. Essential criteria, they are the bare minimal criteria which is to allow the diagnosis of an entity as universally as possible, although molecular criteria are inevitably included for some entities. Okay, so in the essential criteria, only those criteria will be included which can be sought for, or which can be done in a particular third world country. For example, if you are giving certain criteria which are based out of doing next generation sequencing on some molecular testing you have to do, so molecular testing is not available everywhere, and not all countries will be able to afford to provide free of cost molecular analysis for all general public. So that is why they are having certain essential criteria which can be utilized in all the under-resourced countries. Okay, then we have desirable criteria are those that are aiding in the confirmation and refinement of diagnosis, and usually they require the application of advanced techniques. So desirable criteria can be done at places which can afford or which are having the facilities to carry out those testing. Now, for the first time, in an effort to prevent overdiagnosis of lymphoma and to improve the recognition of clinico-pathologically distinct entities, non-neoplastic conditions which are mimicking lymphoma or representing an important differential diagnosis have been included in the WHO 5th edition. So, this is a very important update. Okay, it is a very important update in the 5th edition. So, all the lymphoma mimickers, okay, they are introduced in the starting chapter of the WHO Hematology 5th edition. Okay, and this is the potential question for this year's exam. So the lymphoma mimickers, okay, they are included in the 5th edition. This is the first time that they have been included. Now, in the light of increasing clinical importance and germline tumor predisposition syndrome, which are frequently associated with lymphoid neoplasms such as ataxia telangiectasia, dedicated chapters have been introduced, okay, about those particular neoplastic lesions which are having association with some familial syndrome or with some germline tumor disposition syndrome. In addition, rapid development in the understanding of lymphoid proliferation associated with inborn errors of immunity, that is primary immunodeficiencies, and acquired immune disorders justified significant updates, and these have been included in the 5th edition of the WHO. So a lot of updates has been then in lymphoid proliferations associated with immunodeficiencies, and we will see that in the later half of the video. So these are just some of the broad broad outlines of the changes in the 5th edition of the WHO Hematology. Okay. So first we are going to read in details about the B cell lymphoid proliferations and lymphomas, and after that we are going to see the plasma cell disorders. Okay. So under the B cell proliferations, the first thing that has been included for the first time in the 5th edition of the WHO Hemat 5th edition is the tumor-like lesions with B cell predominance. Yes, this is for the very first time that the WHO has included this entity, and this is a very high probability question for this year exam and in the subsequent exams. Okay. So tumor-like lesions with B cell predominance, what are they? So for the first time, the WHO Blue Book on hematolymphoid tumor introduces tumor-like lesions including 5 entities in a distinct class of tumor-like lesions with B cell predominance. So Castleman disease, if you see, it is not a single disease but rather 3 clinico-pathologically distinct entities wherein you have unicentric Castleman disease, idiopathic multicentric Castleman disease, and you have KSHV or HHV8 associated multicentric Castleman disease. Also included in this section is IgG4 related disease. So IgG4 related lymphadenopathy or disease, very important exam question again. So directly you can read from the WHO 5th edition. Again, this is a very important exam question that is asked in the exam. IgG4 related lymphadenopathy has features that can overlap with Castleman disease. Then apart from these entities, we are having other non-neoplastic B cell predominant lymphoid proliferation involving the lymph nodes and or extranodal sites that can mimic lymphomas, including PTGC, that is progressive transformation of germinal centers, infectious mononucleosis, florid reactive lymphoid hyperplasia, or lymphoma-like lesion of the female genital tract, and systemic lupus erythematosus. Okay, so all these are the reactive lesions which are mimicking. So in the fifth edition, remember throughout this entire discussion, on the left hand side will be the entities of the WHO fifth edition, and on the right hand side will be the entities of the fourth edition. Okay, it is also mentioned everywhere. So this section, that is the section on tumor-like lesions with B cell predominant, was not there in any of the WHO hematology edition. It is for the very first time that they have been included. So what are these? Reactive B cell lymphoid proliferations that can mimic lymphoma. So these are the ones. So these are just the important ones. There are many more which is discussed in the relevant chapters. Okay. So for example, the PTGC, infectious mononucleosis, florid reactive lymphoid hyperplasia, or lymphoma-like lesions of the FGT, SLEs, etc. IgG4 related disease, unicentric Castleman, idiopathic multicentric Castleman, and KSHV and HHV8 associated multicentric Castleman disease. Okay, so all these, okay, they are now under the heading of tumor-like lesions with B cell predominance, and this is the potential exam question for this year. The next important entity under the B cell lymphocytic proliferations are the B lymphoblastic leukemias or lymphomas, that is the precursor B cell lesions. Precursor B cell lesions. Okay, so we are going to see what are the changes that is there in this. Okay, so kindly see, on the left hand side is the WHO 5th edition and on the right hand side is the WHO 4th edition terms. So I am going to take you through some important changes, so pay a lot of attention. Okay, so see, there are certain changes in the terminologies. For example, if you see B lymphoblastic leukemia lymphoma, okay, with hyperdiploidy was there, but they have added high hyperdiploidy as a one term. Okay, also you are going to see one important thing, that in the current 5th edition they have laid down more stress, okay, on the molecular events rather than the cytogenetic event. So the molecular events rather as compared to the cytogenetic event. So this is the cytogenetic event and this is the molecular event, that is the BCR-ABL fusion. Similarly over here, KMT2A rearranged, this is a molecular event and this is a cytogenetic event. Again, this is a cytogenetic event, this is a molecular event. So molecular events are given more importance compared to the cytogenetic events. So as a result, okay, what they have done in the 5th edition, they have omitted these they have omitted these inclusions in the diagnostic term. Okay, so in the term they have omitted this. So for example, B lymphoblastic leukemia lymphoma with translocation 922 BCR-ABL is now read as B lymphoblastic leukemia lymphoma with BCR-ABL1 fusion. Only the molecular entities are included. Cytogenetic entities are not included. Okay, okay. So this is one other change that has been included. That means all these are omitted, okay, from the diagnostic term that we are using. Okay, so you just have to concentrate on the molecular aspects. That's it. Okay, only on the resultant fusion gene product that you are getting. Okay, so only these terms have been retained over here. Else you don't have to use other terms. Okay, so this is the second important change that we are seeing over here. Okay. Now, very importantly, we can see that there are certain new entities that have been introduced. For example, if you see B lymphoblastic leukemia lymphoma with ETV6 RUNX1 features, this is something new which wasn't previously included in the 4th edition. Okay. Also, if you see B lymphoblastic leukemia lymphoma with TCF3 HLF fusion was not included in the 1st edition. Okay. Very, very important that we have to see. Okay. And we have change of terminology that we have already seen. So now let us see the changes. So following the principle of essential and desirable diagnostic criteria, B lymphoblastic leukemia lymphoma can be diagnosed based on morphology and immunophenotype alone as BALL, not further classified. So remember, in all those settings, and it is the same across all the books, all the WHO blue books across all the organ systems, we are now having essential and diagnostic and desirable criteria. So in the essential criteria, so if, for example, because of lack of resources, if you cannot perform further tests, so you should label it as BALL NFC, not further classified. Okay, based on morphology and immunophenotypic alone, you can just give this diagnosis. Now, BALL NOS is to be reserved for those cases wherein you have carried out all the diagnostic tests, all the comprehensive test has been done, and even after that, you cannot place them under a specific category. So, BALL NOS is to be reserved for cases that cannot be classified even after comprehensive testing. Okay. So, most entities under this precursor B cell lesion, they can be classified based on broadly available cytogenetic testing, although molecular genetic subtyping is required for some entities. Now, the majority of the precursor B cell neoplasms are classified in WHO 5th edition according to the ploidy changes such as hyperdiploidy and hypodiploidy, as well as chromosomal rearrangements or the presence of another genetic drivers, as we have already seen the classification. Now, in most of the cases, well-known drivers underlie BALL pathogenesis like amplification, chromosome 21, BCR-ABL fusion, KMT2A rearrange, ETV6 RUNX1 fusion, TCF3 PBX1 fusion, or IGH IL3 fusion. Okay. The classification based on these groups remain largely unchanged from the 4th edition. However, the nomenclature focuses on the molecular events more compared to the cytogenetic alteration, to allow for application of different techniques for their detection. So, as we see over here, we are just concentrating on the molecular events, okay, rather than the cytogenetic event that has taken place, okay. So, remember, this cytogenetic event is not that much important, and therefore, you need not remember them when you are writing down the classification, just what I have already explained. Now, the rare BALL with TCF3 HLF fusion has been added to WHO 5th edition. It is distinct from BALL with TCF3 PBX1 fusion and is characterized by a particularly aggressive behavior. So, as we have already told you, this is a new entity. It is not the same as TCF3 PBX1 fusion. It is a completely new entity in the WHO 5th edition. Why they have recognized it as a distinct entity? Because it has a particularly aggressive behavior. So, this is an important change. Okay, this is an important change compared to the 4th edition. Now, BALL with BCR-ABL-like feature is now a recognized entity. Previously, it was a provisional entity. Now, it is a recognized entity. So, if you see over here, okay, this one, we are talking about this one. This is no more a provisional entity like it was there in the 4th edition. It was a provisional entity. So, BALL, BCR-ABL-like is no more a provisional entity. It is recognized as a proper entity in the 5th edition. Okay. Okay. Now, very important, advances in diagnostic methodologies have allowed identification of another new entity, that is BALL with ETV6 RUNX1 like features. Considering emerging yet limited evidence for separating them in the future as potential novel entities, these new subtypes, so there are many numerous subtypes that is there. Okay. So, they are all and they are getting discovered every day. So, they are, though they are not, yet recognized as a, as a separate entity, but maybe in the future they might be recognized. So, for now, these newer rearrangements or newer entities are placed under BALL with other defined genetic abnormalities. Okay. Okay. So, this is all about the precursor B cell lesion, and these are the changes that we have already discussed. Okay. Next, now we have already covered the precursor B cell lesions. Now we are going to discuss in details about the mature B cell neoplasms in detail. So let us see individually. First, we are going to see the pre-neoplastic and neoplastic small lymphocytic proliferation. So previously, whatever we used to call it as SLL, CLL, okay, they are called as the pre-neoplastic and neoplastic small lymphocytic proliferation. Okay. So let us see what are the updates over here. So pre-neoplastic and neoplastic small lymphocyte proliferations, okay. So basically whatever was there previously, that is monoclonal B cell lymphocytosis and CLL, SLL, they remain. But one entity, that is pro-lymphocytic leukemia, it is no longer recognized as a definitive entity. It is no longer a definitive entity, okay. This family comprises of two entities only, monoclonal B cell lymphocytosis and chronic lymphocytic leukemia or small lymphocytic lymphoma, CLL, SLL. Okay. Now, very importantly, the monoclonal B cell lymphocytosis is having three subtypes now. Now, previously also the subtyping was there, but it has been further refined and further well defined in the latest 5th edition. So, how it is? Let us see. Now, low count. Now, what are the three subtypes of monoclonal B cell lymphocytosis? Let us see. We have low count MBL or clonal B cell expansion. So, over here, the total, the clonal B cell count is less than 500 cells per cubic millimeter. Okay, it is less than 500 cells per cubic millimeter with no other features diagnostic of B lymphoproliferative disorder. Then we have CLL, SLL type MBL. So over here also you are having a monoclonal phenotype, monoclonal CLL, SLL phenotype B cell count, okay, which is more than 500 cells per cubic millimeter, but less than 5000 cells per cubic millimeter with no other features diagnostic of CLL, SLL. Okay. And then we are having non-CLL, SLL type. So any monoclonal but non-CLL, SLL phenotype B cell expansion with no symptoms or features diagnostic of another mature B cell neoplasm. The majority of the cases have features consistent with marginal zone origin. Okay, so let me repeat, we are having low count MBL or clonal B cell expansion. So over here, immunophenotypically, this clone of B cells, they are like CLL, SLL, but the count is very low, is less than 500 cells per cubic millimeter. In CLL, SLL type MBL, over here again the immunophenotypically they are like CLL, SLL, but the only difference is that the range is more than 500 cells to up to 5000 cells per cubic millimeter. And non-CLL, SLL subtype MBL, they are not immunophenotypically similar to CLL, SLL, and over here they are not having any symptoms of any other mature B cell neoplasm, and majority of these cells have features consistent with marginal zone origin. Okay, so let us see what has happened over here in the 5th edition. If you see, okay, and under this heading we had in the 4th edition we had three entities. We had monoclonal B cell lymphocytosis, we had CLL, SLL, and we have B cell pro-lymphocytic leukemia. Now this entity in the 5th edition is not recognized, it is deleted, it is no more an entity. Rather, such group of lesions, they are basically they are subgrouped under other headings, which we are going to see later on. Okay, this is a very important update. Now, very important thing that now WHO has made it very clear how to diagnose each and every entity. So in the diagnosis of CLL, CD5, CD23, okay, 1920 showing that they are B cell origin, and CD5, CD23 and surface or cytoplasmic kappa lambda light chain, okay, they are regarded as essential markers for diagnosis. Whereas other markers, they are additional markers, they are desired markers like CD10, CD43, CD79B, CD81, CD200, ROR1, they are additional targets useful in differentiating the CLL, SLL from other small B cell neoplasms. Okay. In addition, deletion 11q, 13q, 17p, trisomy 12 assessment, TP53 mutational analysis, immunoglobulin gene, heavy chain region variable somatic hypermutation analysis, okay, B cell receptor stereotype subset analysis. These are all essential for a full prognostic evaluation of CLL, SLL. Now there are different kinds of CLL, SLS prognostic scoring system. For example, in the CLL International Prognostic Index, okay, along with age, clinical stage, beta 2 microglobulin level, we are having IgHV and TP53 aberration status. Now this was there in the previous edition also. Okay, now the IPSS scoring for early stage CLL includes IgHV mutation status, absolute lymphocyte count more than 15,000, and presence of palpable lymph nodes. Now, very importantly, if you see in the setting of transformation, the use of term Richter's transformation is recommended over Richter's syndrome. Very important. Okay, so this is again an important change. Now, B pro-lymphocytic leukemia of the 4th edition is no longer recognized in the 5th edition. Why? Because it is quite a heterogeneous thing. And cases that has been labeled as BPLL in the past, actually what they are now subgrouped. How? Let us see. those cases that were reported, they were found to be a variant of mantle cell lymphoma characterized by the presence of IGH-CCND1 fusion, number one, or they were pro-lymphocytic progression of CLL-SLL defined by CD5 positive non-mantle B cell neoplasm with more than 15% pro-lymphocytes in the peripheral blood or bone marrow, or there were other cases which are now classified as splenic B cell lymphoma leukemia with prominent nucleoli. So those which were actually diagnosed as BPLL in the past, they are actually now divided, and they are divided under these three headings. Okay, so now BPLL is no more a recognized entities, they are now included under these entities. Okay. The next important entity is the splenic B cell lymphoma and leukemia. So very important, as the heading goes, the term splenic B cell lymphoma leukemia with prominent nucleoli replaces the hairy cell leukemia variant and CD5 negative B cell pro-lymphocytic leukemia. As I told you, CD5 negative B cell pro-lymphocytic leukemia is now under some separate heading. Like for example, I told you, they are now under the splenic B cell lymphoma leukemia with prominent nucleoli. Okay. So let us see what has changed. Now, very importantly, to make you understand, okay, what are the changes? This is the original WHO 4th edition. So what happened over here, if you see, there was no, subdivisions under the mature B cell neoplasm. Like for example, right now, just we had seen that these entities are now under a pre-neoplastic and neoplastic proliferation of small lymphoid cells. Okay, so they are now under a separate heading. Such headings, they were not there in the 4th edition, but in the 5th edition, they are more organized. Similarly, if you see these entities, that is the splenic marginal zone lymphoma, hairy cell leukemia, splenic B cell lymphoma leukemia, okay, unclassifiable, they were just free. Okay, they were not under any heading. But if you see under the 5th edition, such entities, they are now grouped together under the heading of splenic B cell lymphomas and leukemias. So if you see the hairy cell leukemia, they are placed under such heading. Splenic marginal zone lymphoma under this heading. Splenic diffuse red pulp small B cell lymphoma under a separate heading. If you see over here, the splenic B cell lymphoma leukemia unclassifiable was there. They were actually containing two entities like the splenic diffuse red pulp small B cell lymphoma and the hairy cell leukemia variant. What has happened that this has come out as a separate entity, that is splenic diffuse red pulp small B cell lymphoma is now a separate entity, and the hairy cell leukemia actually is now under a new entity, that is the splenic B cell lymphoma leukemia with prominent nucleoli, along with another entity, that is the CD5 negative cases of the B cell pro-lymphocytic leukemia. These two entities are now under the splenic B cell lymphoma leukemia with prominent nucleoli. So just see, very importantly, the entities are now grouped together properly under the heading of splenic B cell lymphoma leukemia. It includes hairy cell leukemia, splenic marginal zone lymphoma, splenic diffuse red pulp small B cell lymphoma. Now this was under the unclassifiable heading, but it is no more unclassifiable, and it has been properly classified as a separate entity under the 5th edition. Also, a new entity has been introduced, that is the splenic B cell lymphoma leukemia with prominent nucleoli, which are containing two entities. Number one, hairy cell leukemia variant is under this entity, and number two, some cases of B cell pro-lymphocytic leukemia is under now this entity. So these are the basic changes. So whatever I have explained to you, I am just going to read it out so that you can understand once more. The splenic B cell lymphoma and leukemia family in the WHO 5th edition includes hairy cell leukemia, splenic B cell lymphoma leukemia with prominent nucleoli. This is a very new entity that has been introduced. Splenic diffuse red pulp and small B cell lymphoma. Now this entity was there before, but under the unclassifiable heading, but now it is a well-defined classifiable separate entity, and we have splenic marginal zone lymphoma. In contrast to the 4th edition, the splenic B cell lymphoma leukemia with prominent nucleoli as well as the splenic diffuse red pulp small B cell lymphoma, they are now separately classified. Hairy cell leukemia, as we know, it is the same as the previous edition, a mature B cell neoplasm, distinctive clinico-pathological features, and BRAF V600E mutation present in 95% of the cases. Other splenic small B cell lymphoma, they do not have BRAF mutations, unlike the hairy cell leukemia. Now remember, throughout this entire entity that I have explained, always remember whatever have been highlighted in red, they are the changes that has been introduced in the 5th edition. Okay. So the new entity, that is the splenic B-cell lymphoma leukemia with prominent nucleoli, if you see, it replaces the previous term hairy cell leukemia variant in recognition that this proliferation is biologically distinct from hairy cell leukemia, although the leukemia cells may partly resemble the hairy cells of hairy cell leukemia, okay, but biologically and molecularly they are distinct. This is the number one entity under this group. The second entity is, this entity also includes all the cases which were previously termed as CD5 negative pro-lymphocytic leukemia as per WHO 4th edition. Okay, so these are the two entities now placed under the splenic B-cell lymphoma leukemia with prominent nucleoli. Now, SBLPN, it is a rare entity comprising 0.4% of the chronic lymphoid malignancies and affects mainly elderly patients. The neoplastic cells have a prominent nucleus and they are negative for hairy cell markers like CD25, annexin-1, TRAP, CD123. Now, SBLPN is clinically, it is more aggressive than hairy cell leukemia and they are resistant to cladribine as single agent treatment. More recently, improved sensitivity to cladribine in combination with rituximab or bendamustine has been shown as well. Now, splenic diffuse red pulp small B-cell lymphoma has some features overlapping with hairy cell leukemia and splenic B-cell lymphoma leukemia with prominent nucleoli, but can be distinguished on careful evaluation of morphology and immunophenotyping. A CD200 MFI by CD180 MFI ratio less than 0.5 on flow cytometry favors a diagnosis of SDRPL over hairy cell over a splenic marginal zone lymphoma and splenic lymphoma with prominent nucleoli. These entities can be best discriminated by pathologic examination of the spleen. Now, in the absence of splenectomy specimen, bone marrow examination shows characteristic features in SDRPL with prominent intrasinusoidal pattern, while marginal zone lymphoma, splenic marginal zone lymphoma and lymphoma with the prominent nucleoli have a more diverse growth pattern in the bone marrow. And hairy cell leukemia, if you see, they show a typical diffuse pattern with reticular fibrosis. In absence of splenectomy specimen, however, this distinction is not possible. So now we have completed till here. Till here means till these mature B-cell neoplasm. Now we are going to discuss other group of mature B-cell neoplasm. So in this section, we will see the lymphoplasmacytic lymphoma. We will discuss the marginal zone lymphoma. We will discuss the follicular lymphoma, and we will see what are the changes that are there. So first, if we look at the lymphoplasmacytic lymphoma, again over here, the 5th edition is recognizing two subtypes of lymphoplasmacytic lymphoma, the most common being the IgM lymphoplasmacytic lymphoma, also called as Waldenstrom's macroglobulinemia, and the other, which is comprising only 5% of the lymphoplasmacytic lymphoma, is the non-Waldenstrom macroglobulinemia type LPL. Okay, so these include three entities: cases which are having IgG or IgA as the monoclonal antibodies or the proteins, or cases which are non-secretory LPL or IgM LPL but which does not have any bone marrow involvement. Okay, so this is the basic classification of the lymphoplasmacytic lymphoma. Now, as it was in the previous edition, so is here. There are two molecular subsets in IgM LPL type based on the presence or absence of MYD88. So there are two subsets. One subset which is having MYD88 mutation, another which does not. And this is regarded as the hallmark driver mutation in vast majority of LPL, that is in more than 90% you will have this mutation. Now, demonstration of this MYD88 mutation is difficult. It is helpful in difficult differential diagnosis with nodal and extranodal marginal zone lymphoma with plasmacytoid differentiation and plasma cell myeloma. Now, the two latter entities generally lack the MYD88 mutation with the exception of rare cases of marginal zone lymphoma. Now, CXCR4 is another group of mutations seen in 40% of all lymphoplasmacytic lymphomas, usually concurrent with the MYD88 mutation. Okay, so this is about the lymphoplasmacytic lymphoma and not much changes have been there over here. Okay, now we will discuss the marginal zone lymphoma. Now, if you see, most of the entities, they are the same. That is the extranodal marginal zone lymphoma of the Mal tissue was there before, it is here now. Nodal marginal zone lymphoma was there before, is included here now. The pediatric marginal zone lymphoma was there, is now as well. The only new thing is that The primary cutaneous marginal zone lymphoma was previously under the heading of extranodal marginal zone lymphoma. It has come out of that as a separate entity. That is the only change. Not much change is there in the marginal zone lymphoma. If you see marginal zone lymphoma, if you see the cytogenetic mutational profiles, just the only changes that are there in the 5th edition is that marginal zone lymphomas, okay, the mutational changes or the molecular changes, okay, in the marginal zone lymphomas in different anatomical sites are different. So the molecular changes, they differ by the anatomic site, and the cutaneous marginal zone lymphoma, they achieve independence. As I told you, they have come out from the extranodal variety as a separate entity in this 5th edition. So extranodal marginal zone lymphoma of MALT and nodal marginal zone lymphoma featured as distinct entities in 4th edition. They are same and they are retained in the 5th edition. Pediatric nodal marginal zone lymphoma upgraded from a subtype under nodal to a separate entity. This is again one important change, but not very big change. Now, primary cutaneous marginal zone lymphoma has been designated as a separate entity in the 5th edition. Okay, this is again the same. Now, extranodal, nodal and pediatric marginal zone lymphoma, they are having overlapping histological and phenotypic features. The neoplastic cells, they are mature small B cells, typically negative for CD5, CD10. Now, plasmacytic differentiation are very common in the marginal zone lymphomas, and associated reactive lymphoid follicles are often present. However, despite some shared features, they have different etiologies and pathogenesis, with further differences among the extranodal marginal zone lymphomas arising in different anatomic sites. Remember this point. Now, for example, among all the marginal zone lymphomas, trisomy of chromosome 3 and 18, they are common. Now, gain of chromosome 2p6p and loss of 1p6q are frequent in nodal marginal zone lymphoma. However, gain of 6p, loss of 6q are recurrently seen only in extranodal marginal zone lymphoma of ocular adnexa. Translocation involving MALT1 such as 11-18 translocation resulting in BERK3 MALT1 fusion are recurrent in gastric and pulmonary extranodal marginal zone lymphoma. So what is happening, that extranodal marginal zone lymphoma, okay, their molecular changes or molecular pathogenesis is different in different anatomical sites. This is what has been emphasized in this edition. But in contrast, no recurrent gene fusions or rearrangements are described in pediatric or nodal marginal zone lymphoma. The mutational profiles of extranodal and nodal marginal zone lymphomas, they differ. In addition, there are significant genetic difference among extranodal marginal zone lymphomas arising in different anatomic sites, as we have already seen. Okay. So these are some of the changes in the marginal zone lymphomas. Now we are going to see the follicular lymphoma. So in the 4th edition or in the previous editions of the WHO, we have classically seen and read about the grading of follicular lymphoma. So let us now revisit what was the grading of the follicular lymphoma that we have seen. So if you see, we are having grade 1, 2, that is grade 1, 2 and 3 follicular lymphoma. So grade 1 and 2, they were low grade follicular lymphoma characterized by the presence of 0 to 15 centroblast per high power field. Grade 1 was when there was 0 to 5 centroblast per high power field, and grade 2 was 6 to 15 centroblast per high power field. And grade 3, they were when there was more than 15 centroblast per high power field. And again, they were subdivided under grade 3A and 3B. So 3A follicular lymphoma was the one which at least showed some centrocytes. Okay, some or few centrocytes were yet present. Then it was regarded as 3A. If no centrocytes were seen and only solid sheets of centroblast were present, it was graded as 3B. So this was actually present till the 4th edition, but in the latest 5th edition, WHO has scrapped this grading system, okay, because it doesn't carry any prognostic or any clinical value is not there with such grading. Okay, so this has been done with in the latest edition. So let us see. Follicular lymphoma, from classic grading to biological grouping. The family of follicular lymphoma encompasses follicular lymphoma, in situ follicular B-cell neoplasm, pediatric type follicular lymphoma and duodenal type follicular lymphoma. So there is no significant update with regards to these last 3 entities. Okay, that is the in situ, pediatric and the duodenal type FL. In contrast, the entity follicular lymphoma has undergone a significant revision. So what is the revision? Let us see. Vast majority of follicular lymphoma, around 85%, have at least in part they have a follicular growth pattern, and they are composed of centrocytes, centroblast, and they harbor the translocation 1418 associated with IGH BCL2 fusion. These are termed classic follicular lymphoma. This was there before also, it has now also. Okay, and along with this follicular lymphoma, so we are actually discussing the subtypes. So around 85% they are the classic follicular lymphoma with these features. Apart from this, we are having other subsets. Okay, what are they? Then they are follicular lymphoma with B cell lymphoma, follicular lymphoma, follicular large B cell lymphoma. Okay, follicular large B cell lymphoma, and the third subtype under follicular lymphoma is follicular lymphoma with uncommon features. Uncommon follicular lymphoma is there. Okay, so in the WHO 5th edition, grading of follicular lymphoma, which is only pertinent to classic variety, is no longer mandatory. So it is no longer mandatory to grade. It is optional now. Clinical outcomes among, why it is optional? Because the clinical outcomes among patients with follicular lymphoma grades 1, 2 and 3A are not very different. So it did not make any sense, okay, to have such grading. Now, one important thing is that about the 3A, very rare cases of grade 3A classic follicular lymphoma, they may show a focal or extensive diffuse growth pattern. In the WHO 4th edition, the recommended diagnosis in such cases was DLBCL with follicular lymphoma, even though sheets of large cells are not present. Currently, it is uncertain whether such cases should be classified as classic or DLBCL. So you have to sit, you have to have a panel discussion, you have to have an ethic committee, and then after that it should be decided whether it should be placed as a classical follicular lymphoma or DLBCL, not directly. So such cases having a diffuse growth pattern automatically should not be labeled as a DLBCL with follicular lymphoma as it was done in the 4th edition. Okay, now the subtype of follicular lymphoma, follicular large B cell lymphoma largely equals to WHO 4th edition FL grade 3B. So follicular lymphoma grade 3B, okay, is now labeled as follicular large B cell lymphoma. Okay, just remember this thing. And this renaming was just done because so as to maintain a consistency through the classification. So follicular lymphoma grade 3B is now labeled as follicular large B cell lymphoma. Remember this term. So we have a classic variety. Follicular large B cell lymphoma is similar to the follicular lymphoma grade 3B of the past. A new term that has been introduced is a new subtype is the uncommon variety of follicular lymphoma, and it is having two subsets that is significantly different from the classic follicular lymphoma. The one is with a blastoid or large centrocyte variant cytological features, and the other which is having predominantly diffuse growth pattern. Okay. Now, follicular lymphoma with blastoid or large centrocyte cytological features more frequently display variant immunophenotype and genotype characteristic, and they may show inferior survival. They need to be distinguished from large B-cell lymphoma showing IRF4 rearrangement. Follicular lymphoma with predominantly diffuse growth pattern frequently occur as a large tumor in the inguinal region and associated with CD23 expression, and absence of IGH BCL2 fusion and frequent STAT mutations along with 1p36 deletion. Separating such cases from classic follicular lymphoma will support research to clarify the disease biology, allowing a better definition. So this is a new entity that has been created, and they have two subsets, that is the follicular lymphoma with blastoid or large centrocyte variant and with a blastoid and with a diffuse growth pattern variant. Now we are going to discuss about the mantle cell lymphoma. Now very importantly, you have to understand nothing much has changed in the way of mantle cell lymphoma as such from the 4th edition. Only there is improved risk stratification that is there for the mantle cell lymphoma. So let me just show you. Okay. The WHO 5th edition groups mantle cell neoplasia into 3 different chapters. So there are 3 entities over here. As we can see, there is a in situ mantle cell neoplasm, mantle cell lymphoma, and leukemic non-nodal mantle cell lymphoma. All these 3, they were also present in the 4th edition. So there is not much difference as such. In situ mantle cell neoplasm, it is rare and typically it is an incidental finding. It represents colonization of mantle zones of lymphoid cells by B cells carrying IgG CCND1 fusion leading to cyclin D1 overexpression. This is very important. And this fusion leads to translocation 11-14. It is a genetic hallmark of mantle cell lymphoma present in more than 95% of the cases. Now, in occasional cases of mantle cell lymphoma that strongly expresses cyclin D1 protein but shows no CCND1 rearrangement by FISH, but genomic studies in such cases shows cryptic rearrangements of IgG-K and IgL enhancers with CCND1. So the rearrangement is there, but it is cryptic. So you have to do further studies. In a small subset of MCL, negative for cyclin D1 as well as negative for CCND1 rearrangement, okay, they were, they showed some other rearrangement, that is CCND2, CCND3 and CCNE rearrangements were identified in such, and they were the alternative mechanisms of cell cycle dysregulation seen in such kind of mantle cell lymphoma. In recent years, the median overall survival of patients with mantle cell lymphoma has dramatically increased because of improved therapies. Therefore, identification of prognostic subgroups of mantle cell lymphoma has become highly relevant because of the good outcome. So we have to identify such prognostic subgroups, okay, and give them the targeted therapies. Widely available and best established biomarkers of high-risk mantle cell lymphomas include cytomorphology. So pleomorphic or blastoid appearance will have a bad prognosis. High Ki67 index, p53 expression and TP53 mutation. So presence of any of them will have a bad prognosis for mantle cell lymphoma patient. Non-nodal mantle cell lymphoma is characterized by involvement of blood, bone marrow and spleen, little or no lymphadenopathy, a mostly asymptomatic presentation and a better clinical outcome compared to mantle cell lymphoma.